You got a family, you're busy. I know, we've been through it, been there, done that. Um, Walk with me, guys. Today I'm going to show you just to kind of how I kind of go through um, information that may be new to me or information that I've gone through in the past. Um, the purpose of this video is to give you kind of like a framework just to show you how I think about stuff. Um, Important things to remember as you go through this and as we go through this. Uh, it's very important that you find some method of active recall. That's going to be essential for you to maintain or do deep learning and essentially ensure that you keep remembering the things that you've learned. Active recall can come in many forms. Today we're going to go through one particular type, and that is going to be in the form of Q bank or questions. Now, I've created a 10 questions today, so we're going to go through 10 questions. Now, the way to make this really work is you're going to go through these questions yourself as I'm also going through them to myself. And so the answers, the answers, they don't matter. This is an exercise in building a particular system that you're going to work through. I really want you to keep that in mind. The answers, they matter in the grand scheme of things, but as we're going through this, don't beat yourself up over if you got 10 wrong, if you got one right, if you got whatever your score is, the score doesn't matter. The real learning is happening by going through the material, struggling with the material, and ultimately learning the material. Okay, so this is going to be an important disclaimer as we go through this. So our topic today is going to be respiratory anatomy and physiology. Um, Very high yield topic for those people in anesthesia. So if you're studying, if you're a new resident, if you're a CRNA or SRNA, this is a topic that will never go away. The physiology doesn't really change, so it's really important to kind of learn it and get it down pat. And so that's going to build your foundation for the rest of your career. Okay, so we'll go through 10 questions and pause the video, do whatever you need to do. Just make sure that you're engaged with this material as much as possible. Okay. Now, the other thing I do want to make sure that you understand is that when you decide to sit down and study and review, like we're about to do now, it's super important that you try to limit as many distractions as much as possible as you can, okay, within reason. So I would say to you that the cell phone, either put it on do not disturb or put it in a room somewhere far, far away. You got to dedicate this amount of time, whatever it is, if it's 30 minutes, 15 minutes, 1 hour, to high yield output. Okay. No distractions. Make sure you have your water, make sure you have everything that you need. But once you decide to sit down and do the work, it's time to get the work done. Right. So make sure everybody around you understand that it's grind time right now. Okay. All right. So let's get into it. So 10 questions I've created. Towards the end of it, there we're going to go through the answers. And it's important too, right? The answers are important, but the score, not as much. Okay. So let's get into it now. We'll start with the first question. Okay, so a patient requires an awake fiber optic intubation via the nasal route. So in order to anesthetize the nasal mucosa, which nerve must be blocked? Okay, so olfactory, facial, trigeminal, glossopharyngeal, vagus. So I'm gonna go ahead and answer these questions together with you. Sit down, you think about it, and then we'll go through it together. So for number one, I'm gonna go ahead and answer. And I'm not going to tell you my answer. You keep your answer to yourself. And we'll go through all of them together. Okay. Uh, Question number 2 is going to be this. Okay, an unconscious patient is evaluated before transfer to the operating room. Deep suction is placed to the back of the patient's throat. No gag reflex. Which of the following nerves is responsible for the sensory portion of this reflex? Okay. So I am going to go ahead and select my answer here. And you take your time. You select your answer here. All right. So now, when you go through these questions, I know there's multiple ways to do this. I know people like to question and answer at the same time. I find that when you're limited for time, or when you work in, when you don't have an infinite amount of time, like most of you people watching this video, that can, it's a slow grind, right? I think you need to get the reps in. So you need to see the questions, you need to see what you know, see what you don't know, identify those things quickly. So it's going to be really tough to do that if after every question you're looking for their answer and so on. Okay, so I recommend that you go through the questions quickly, and then the real learning is going to happen as you go through the answers and you go through the material and so forth. Okay. All right. So number 3 is name the anatomic border between the oropharynx and the laryngopharynx. Okay. So that's going to be this answer. Okay. Take your time. Pause it if you need to. I'm gonna move on to the next question, okay? Okay, question 4. The laryngeal muscles that abducts or abduct the vocal cords. This is a question that never goes away. Okay, so it's this one here. Okay, how are we doing so far? Good. All right, I'm gonna move on to question number 5. 5 is going to be name the laryngeal muscle innervated by the external branch of the superior laryngeal nerve. Okay, laryngeal muscle. That's going to be this. Okay. Can we move on? Yep. Move on to question number 6. In the larynx, the posterior aspect of the vocal ligaments attached to which of the following cartilages? And the laryngeal and the posterior aspect of the vocal ligaments attached to which? Okay. That's going to be this. Okay. Question number 7. All right. You messed up. You popped the balloon instead of deflating it like you should before extubating. Now the patient notes significant hoarseness. You evaluate the patient's vocal cords. Diagnostic fiber optic examination is performed. If unilateral injury to recurrent laryngeal nerve has occurred, what will be the position of the affected vocal cord? Okay, let's go ahead and fix this. Okay. Also, two lessons here. One, don't pop the balloon, always deflate it. Um, and the answer to this question is important. And I'm going to say this is going to be C. Okay, number 8. Routine lab choline. Previously well, patient is noted to have complete unilateral vocal cord paralysis in the PACU. Which of the following treatment options is most likely required? Okay. Go ahead and get this here. Next question. The adult larynx versus the pediatric larynx. Select the most correct statement. This. Okay. Tough questions, easy questions, let me know. Or just right. And emergency cannot intubate, cannot ventilate situation. Anesthesia team prepares for a percutaneous surgical airway. In order to secure the airway, which of the following anatomic sites should be assessed? This one should be easy. Should be this. Okay. All right. And before we get into the answers, was that too tough? Was that just right? Is that too easy? You guys will let me know in the comments. Essentially, this is a basic science portion. Okay, now I know a lot of you are watching this. You guys are preparing for your MCATs, or preparing for your boards, whatever it is. It's going to be the same sort of flow. Always, whatever your form of active recall is. Today we're choosing to do questions first, see where you are, answers, then deep dive into the answers. Okay? All right. So, question, let's go through the answers. Okay. So, I'm going to put the answers up here. You guys go ahead and see how well you did. Remember, doesn't matter. Okay? But just go ahead and check yourself here. Okay. All right. So, next thing I like to do, we will go through all the rationales and all of that. Okay. But just walk with me here. Bear with me. The next thing I like to do is, once I have these questions done, I try to ask myself, what was the main point? Like, what was the point of these questions? And what topics they cover? So in anesthesia, we like to do something called keyword division. It's really important that you try to really look at the question and try to get what the main event was. Okay, so for the first question, if you can go back, you ask yourself, number one, what was the main event for this? Okay, so I'm going to say to myself, well, this was trying to help me understand the anatomy of the nasal cavity and its importance for an awake fiber optic. Okay, all right, that's what I say from this. That's what I get. All right, um, or you can say, I guess, nerves needed or nerves targeted for nasal intubation, awake fiber optic. Okay, I think those two things need to be placed together um, for you to really get the best out of it. Right. So every time. Number two, we said the answer to that was C, trigeminal. Okay, good. We'll come back. Okay, this exercise is important also too. Okay, number two, question two was this was the unconscious patient, the gag reflex. Okay, so this was going to talk about the gag reflex, the arc. So we need to know the efferent and the afferent pathway. All right. Really important to understand the efferent and afferent pathway of a gag reflex. Okay. All right. Good. Why is that important in anesthesia? You can understand the patient's gag reflex. For whatever reason, the gag reflex is ineffective or blunted. And so sometimes we want that to happen. Sometimes it's as a result of pathology. And understand that if it is as a result of pathology, this patient's airway is severely compromised. And so they may need a breathing tube. Okay. So it's important to understand the innovation there for that. Okay. Then number three is going to be name the anatomic border between the oropharynx and the laryngopharynx. Okay, so this is anatomical structure again, anatomy of the upper airway, and this one is asking about the borders. So we can say the borders of the you can say, if you're in your notes, you're going to do the borders of the nasopharynx. You see the borders of between the oropharynx and the laryngopharynx. Which of these structures essentially divide them when you're looking at a mannequin or when you're looking at a patient. Okay, and then number four is going to be this laryngeal muscle that abducts. Okay, so this is going to be vocal cord anatomy or muscles. Okay, it's really important. What muscles make the vocal cords open? Or AB duct or AD duct? Okay, really important. So we have a list of muscles there. Try your best to identify every one, their function. And this question is actually a lot easier than you may think, because the vocal cords, as simple as or as complex as you may believe it to be, you can actually really silo it in turned it into muscles that open and muscles that close. And once you understand those, and it's really easy. And so muscles here, so that's the important thing to know. 5. That's going to be for your note system if you have it. What I have done lately is these notes, I convert them into like audio notes. So I'll record my notes as I make them. And so I just play them over and over. Or you can write them and then repeat them over and over, sorry. Whatever works for you. Okay, number 5 is going to be another question that kind of ties into the last one. So this was the laryngeal muscle innervated by the external branch of the superior. Okay, so this one talks about the laryngeal muscles, but then it specifies, it goes a little bit deeper now. It talks about not just the muscles, but the nerve innervation. This is like a popular pimping question. All right, so this one here. So it talks about the superior laryngeal nerve particularly. So you can break it down into the external branch, which is what the question is asking about. And then you can't have one without the other, right? So internal branch also for when you're making your notes. Okay. And then number 6 is going to be talking about in the larynx, the posterior aspect of the vocal ligament attached to which of the following? Okay, again, talking about the entry point, the the muscles of the larynx, and in relation to the vocal cords. Okay, larynx, vocal ligament. All right, so this one now kind of breaks it down into the cartilages. So they want to know about the cartilages that attach to the posterior vocal ligament. So this ties into a bigger picture of in the anatomy, understanding the not only the muscular component, the nerve innervation, the blood supply, and the cartilage of the airway. Okay. Number 7. Number 7 was loaded with some sassiness. All right, you messed up, pop the balloon, yada, yada, yada. Let's see, validate the patient. Okay, so this was, I guess you can say, unintended injury from intubation. All right, so essentially the damage is a unilateral recurrent laryngeal nerve. Okay, so earlier questions asked about the superior laryngeal nerve. So this one is asking about the recurrent laryngeal nerve with damage. How does the vocal cord look if damaged? Okay, unilateral. And then question 8, ask about unilateral vocal cord paralysis. Now that kind of piggybacks off of question 7. So now you have, because the same patient, let's just say it's the same patient, they have a unilateral vocal cord paralysis. This one goes a little bit deeper now, is talking about management. So management of, you can put this under management of vocal palsies. That's going to be your topic. All right. Essential when you're in the PACU. Um, essential just to know all the way around. Number 9 talks about the adult larynx versus the pediatric. All right, so this is, love to do this. It's understand that the airway is not, the pediatric airway is just not the smaller version of the adult airway. It has very unique characteristics. And so it's really important to understand the unique characteristics of the pediatric airway and how that pediatric airway eventually turns into an adult airway. And so they want to compare the adult larynx versus the pediatric larynx. Okay, so really important. Adult versus peds larynx. That's the question. And then 10. And this is a can't intubate, can't ventilate scenario. And now you need to manage that. So management of can't intubate, can't ventilate, and then the anatomy. So this exercise is doing two things. One is allowing you, when you're making your deep notes, into broadly categorized stuff so you can keep your information really organized. The second thing that I think is really important is how can you now rephrase any question that you're presented with into its simplest form, and so that you can answer it. Because when these questions are long and drawn out, like some of these USMLE questions in the past that are just 4, 5, 10 sentences long, how can you break it down into a simple one-liner? Right? So the ability to do that is really important. And so this one, I can just get through all this fluff and say, what's the most important anatomic structure for doing a percutaneous surgical airway, performing a percutaneous surgical airway, and then you can answer that. I don't know if you got that the first time around, but that's essentially what's asking there. All right, so, okay. All right, so we did that. We saw our answers. Okay, so let's see. I kind of broke this down and let's see if it matches. Okay, the airway innervation. Okay, we said that. The gag reflex, the pharyngeal borders, intrinsic laryngeal muscles and their actions, recurrent laryngeal nerve versus superior laryngeal nerve, injury, clinical distinction, and court positions. Okay, good. Pediatric versus adult airway differences, can't intubate, can't ventilate management, and surgical airway techniques, the awake fiber optic, 3-zone approach, cricoid anatomy, and clinical implications. Okay, so those are the topics that were covered in these 10 questions. All right, so you don't need to say everything word for word. You need to be able to get the gist of it, and that's important. All right, so I'm gonna change my screen now to go through just some of the learning. Okay. And now, guys, if you want these particular questions and then anything of this, anything that we've spoken about here, I can put these in a PDF form that will be available. You guys will let me know in the comment. Now, one amazing thing that I think is really revolutionary and really revolutionary in the field of like just learning and education is AI. And so AI is a tool like everything else. You use it correctly, I think you can, sky's the limit as to what you can do from an educational standpoint, from a productivity standpoint, and so on. And so I have been dibbling and dabbling with AI with my education, my learning, and I believe it's like game changer for me. And I think it would be game changer for you also. So let me take a look. Let's take a look and let me show you what I did here with this. Okay. Yes. Okay. All right, good. So again, so we've done questions, we've gone through the topics, and now what I want to do, your next phase, so learning on three different levels: the testing, then now a little bit of a deep dive in the form of more active recall again. So from question number one, if you can go back to it, what I did here was I put together some questions I think that are like high yield that touch on the topic that was asked. Okay. So, in a broad sense, so if we're going to say that the first question was talking about the, the anatomy of the nasal cavity and the importance in a wake fiber optic. And so I just went in and I asked AI to create important questions based on that I should know. All right. Now, caution: when you ask whatever your AI tool is to do these questions for you, they can send you down a deep, deep, deep rabbit hole. It's really important to just kind of just take one or two things and move on, because you're going to run into the problem of now trying to learn every single thing that it may ask, it may produce for you, and you get information overload. So I caution you, don't go into the rabbit hole. All right, these AI modules, programs, or apps, they want to keep you in the app. And so don't fall into the trap. All right. So, based on the first question, here is some more questions. So, which nerve provides, so we just went through that, which nerve provides sensory innervation to the nasal mucosa? And we went through that and we understood that that was the trigeminal nerve. Okay. So, here's some more information here. So if you want to talk about the anatomy, the nasal mucosa innervated by cranial nerve 5, the anterior ethmoid V1, that's broken up into three components: V1, V2, V3. For the sake of in the interest of time, we're going to just briefly go through that. V1 is the anterior ethmoid that covers the anterior septum, the nasal cavity, and as well as the turbinates. Okay. The sphenopalatine ganglion, which is V2, covers the posterior septum and the lateral walls. So the SPG is the primary target anytime you're going to do nasal topical anesthesia. So if any of you have been in nasal surgeries, and so you may see them use either oxymetazoline and or topical cocaine, pledge it into the nasal cavity. And so you're really trying to target the sphenopalatine ganglion. Okay. So important things to know. All right. So here, okay, good. So here's some high yield pearl. The topical options: 4% cocaine, or oxymetazoline or Afrin, plus 4% lidocaine. SOPA pledges and advance the posterior turbinate to block the SPG. Zone rules: the nose, if you break the nasal cavity into three zones, nose being the first, that's to target in cranial nerve 5, the throat 9, and the larynx 10. So it's going to be 5, 9, and 10. Those are the essential nerves that need to be targeted to successfully do a smooth, look like a pro nasal intubation. Okay. So moving on. Second, which nerve carries the afferent or the sensory limb of the gag reflex? Okay. So we said that this was going to be the glossopharyngeal. Right. So understand that cranial nerve number 9 carries the afferent signal to the posterior 1/3 of the tongue. Okay, so the tongue, you can break it up into thirds: posterior 1/3 and the anterior 2/3. So the posterior 1/3, the glossopharyngeal, I always think of it as the most posterior innervator. So it covers the posterior 1/3 of the tongue, all the things in the back, the soft palatine, posterior laryngeal wall, to the nucleus tractus solidaris in the medulla, and then cranial 10 is going to be the efferents. If you have that mnemonic where you talk about the what does sensory and what does motor, try to use that into, you would behooves you to remember that um, the vagus nerve does well with a lot of motor function. Okay, it does have a sensory, but it primarily has a motor component to it. And so it's a cranial nerve. Number 10 is the efferent limb. Okay, all right, some high yield points. Absent gag does not equal safe airway. Cranial 10 still mediates laryngospasm independent of the gag reflex. Okay, so what this is saying that even though you don't have a good gag reflex or a non-existent, that does not protect you. You still can have a laryngospasm. Hence, this is why it's very important to be able to secure somebody who cannot protect their own airway. Okay, an absent gag in a trauma patient implies brainstem pathology until proven otherwise. All right, so good. There's some high yield stuff there. All right. Okay, next one. So can't have one without the other, right? So if this question was to ask you about, the last question asked you about the afferent. So now this is going to be the efferent. So what do we say? We said that the efferent motor limb of the gag, that's going to be cranial nerve 10. Okay? So you're using the tools that's readily available to you to blend them into your study flow to give you maximal productivity. All right, so here's some high yield facts. 9 and 10, both are in the medulla. Here's some more for all my great anatomy folks. Both nuclei in the medulla. This critical localization point. The gag reflex test usually tests cranial 9 and 10. That's the integrity. So on a physical assessment, my bedside practitioners, you do gag reflex, you're testing 9 and 10, with 9 being the sensory component of the gag reflex and 10 being the motor component. Okay? So sensory 9, motor 10. Okay? What anatomic landmark separates the oropharynx from the laryngopharynx? Okay, so this one is, so in anesthesia, the things that are, like I said, the anatomy doesn't change. The physiology rarely changes also. There are just certain things that are just more important than others, okay? So just in knowing that fact, well, if you're just starting off, you may not be able to understand that. But just as time goes by, there's certain structures that are just way more important to know than others, okay? And by nature of just questions asking you about them in just the weirdest ways possible, the things that are important are always going to be important, okay? So we know that the epiglottis is a very important landmark. It's important for direct laryngoscopy. It's important to just understand. So now here's another importance. So you understand that the epiglottis is that landmark that separates the oropharynx and the laryngopharynx. Voila. So the tip of the epiglottis marks the inferior boundary of the oropharynx and the superior boundary of the hypopharynx. Okay, above oro, below hypo. So here's some high yield. The three borders, the soft palate, the nasal and oropharynx. The soft palate is what separates the borders. The epiglottis. So we move in from superior to inferior, or cephalad to caudal. We're going to say the soft palate, nasal, oral, epiglottis, oral, hypo, inferior cricoid, which is C6, separates the pharynx and the esophagus. Here's some important anesthesia stuff. The Mac blade lifts the vallecula, which is in the oropharynx. The Miller lifts the epiglottis itself. So physically crossing this border. Voila, pearls. All right, which landmark separates the nasopharynx from the oropharynx? So we said that earlier. If you go back and remember what we just spoke about, say it aloud, say it to yourself. The nasal and the oral is separated. We're moving, always move from cephalon to caudal. We'll know that that's going to be the soft palate. Okay. The soft palate is a superior palate. We went through that. Okay. And then you guys can read this. I can link this to it if you want it. Okay, next one. Which intrinsic laryngeal muscle is the only abductor of the vocal cords? Okay, so the way I learned this years ago was the way I memorized this, I should say this, years ago, was abduct, taking something to the back. Another word for back is posterior, right? So abductor, the only abductor of the vocal cords, the only thing that takes things back is going to be the posterior cricoarytenoid. Okay. That might not work for you. It worked for me. However you learn it, please, if you guys have another way that you learned it or memorized it, yeah, share. I'll take. This has worked for me for years, so I'm rocking with it. But I'm always open to learn new stuff too. So let's go. Now, the PCA is the sole abductor of the vocal cords, right? And earlier I said that when you take a look at these laryngeal muscles, they're not that hard to learn, right? So if you want to take it just one step further, I would say to you that what you can do is to actually look and identify the anatomy on a mannequin or a cartoon, and so that you be able to understand where they are in relations to each other, and just kind of visualize or get some animation and see how they work in tandem as we're speaking, as we're singing, as we're doing just day-to-day life. Okay, so the PCA is the sole abductor of the vocal cord. It originates on the posterior cricoid lamina, inserts on the muscular process of the arytenoid, and rotates the arytenoid laterally. I'm going to ask myself, what is the function of the posterior cricoid arytenoid? So it is the only abductor in the only abductor of the vocal cords. Its one sole job is to essentially abduct vocal cords. It's not its only job, but for the sake of argument, I'm going to say that and keep that in my head. All right. And again, it originates, it's a posterior that originates on the posterior cricoid lamina. Okay. All other intrinsic muscles are either adductors or tensors. Remember that. The posterior is the only one that abducts. All other muscles are either going to be adductors or tensors. Here's a high yield pearl. Bilateral PCA paralysis signals that this is a bilateral recurrent laryngeal nerve injury. So the cords fall to near midline, which leads to stridor and respiratory distress, which is a surgical emergency. Unilateral leads to hoarseness only. Why? Because the contralateral cords, they're going to go ahead and compensate. If you only have this one muscle doing this particular task, understand why its failure doesn't have any backups. Okay? The unilateral recurrent laryngeal nerve only will give you hoarseness, but the contralateral muscles are going to sort of pick up to protect the airway. The body is always trying to protect itself. Okay, let's go. Next up is going to be the bilateral recurrent laryngeal nerve transection causes the vocal cords to rest, in which position And so I don't know how many of you got this, but this is a question that loves to be asked. It's always going to be in the paramedian. Yeah, no, bilateral. This should be a paramedial. Nope, I'm wrong. Wrong question. This is going to be near midline. Okay. Bilateral recurrent laryngeal nerve transection causes the vocal cords to rest. Okay. Yep. Bilateral recurrent laryngeal loss leads to bilateral PCA paralysis. Without function adductors, the cords drift to near midline. If the cricothyroid is also lost, the cords reach true midline. Okay. Which leads to complete aphonia. So the worst possible thing that can happen is a bilateral recurrent laryngeal nerve injury. Remember that? That is typically observed, stridor is typically observed in this pathology and respiratory distress. If it's only hoarseness, it's not a bilateral injury. So this is always going to be a surgical emergency. Typically, these are the things that you worry about for a patient who has had thyroid surgery or any patient that has had these ACDFs or thoracic aortic aneurysms repair and so on. Always need to assess their voice, hoarseness, a little bit okay. Stridor and respiratory distress is never okay. Okay. Number 8, which intrinsic laryngeal muscle is innervated by the external branch of the superior laryngeal nerve? Okay, the external branch, this is a question that's always going to be asked. Always remember it's the cricothyroid. Draw the anatomy, learn the anatomy, draw it 10 times over and over when you have the time. See them in a cartoon, learn it, love it. Okay. The cricothyroid is the only intrinsic laryngeal muscle innervated by the external superior laryngeal nerve. Okay. Things like that. Also try to pick up when you're doing your reading and you see things like this is the only one, or this is the most rare, or this is the unique. Terms like that, whenever you see them, I always want to take special attention to that, because boards and stuff like to ask you about routine stuff, but they also like to throw in rare and rare stuff and unique stuff like that. So it's very easy to get like questions correct whenever you see kind of wording like this in text. Okay. And then some high heel pearls. External laryngeal nerve runs superior to the runs near the superior thyroid artery. Ligate vessels close to the gland protected. Subtle hoarseness, pitch loss, vocal fatigue. Singers are devastated, so it's easy to miss, often misdiagnosed as laryngitis. All right, next up, the internal branch of the superior, can't have one without the other. All right, the internal branch now of the superior laryngeal nerve provides sensory innervation to which region? Okay, so if we're going to talk about the external branch, talks innervating the cricothyroid muscle. The internal branch has way more function. Okay, so we're going to go ahead and say that this is going to be supraglottic, larynx, epiglottis, and piriform sinus. So the way I remembered these was the recurrent laryngeal nerve sort of takes things below at the vocal cords and below, so like primarily the trachea. Things above, or the anterior portion of the epiglottis, typically is going to be divided between the sensory is going to be like glossal and superior. So if you're talking about superior laryngeal nerve, the supraglottic, so above the glottic opening, the larynx, the epiglottis, that's really the anterior portion of the epiglottis, and the piriform sinuses, those are covered by the superior laryngeal nerve. Okay. So here's a little fact to know: a superior laryngeal nerve block for an awake fiber optic. This is how you do it. Rarely done. I don't know many people who can do them in this day and age, but good to know. I think boards like to ask you stuff like that. You need to know how to do at least do a superior laryngeal airway block. So that's going to abate the sensation from the epiglottis to the supraglottic. Okay. Some more anatomy. The posterior aspect of the vocal ligament attaches to which cartilage? And we know that that was the arytenoids. You have to see and learn the anatomy to get this question. This is kind of just like it's either you know or you don't know kind of fact. And then you can kind of go through this. Some high yield stuff. Arytenoid granulomas form at the vocal process, the exact ETT contact point. Risk factors, so patients who've had prolonged intubations, patients with oversized tube, or high cuff pressure can lead to these granuloma formation. Patients with poorly controlled GERD. This can present weeks post-extubation as persistent hoarseness. So patients, they say, oh, I was intubated for so long, my voice really changed. You really have to start thinking about like arytenoid granulomas. So for these patients, a smaller ET tube would be the best technique for them, and also keeping cuff pressure less than 30 centimeters of water. Okay, the muscular process of the arytenoid cartilage serves what primary function? So the muscular process of arytenoid cartilage serves the primary function that it pivots for abduction via the posterior cricoarytenoid and the lateral cricoarytenoid insertion. Okay, so can do this. All right, so I'm gonna stop at this. I think we've been going now for about an hour. So typically you have a timer, you go through this. We covered a lot of stuff here. I know it may not feel, maybe it feels like it, maybe it doesn't. We covered a lot of stuff here, all right? So I'm gonna stop. This is an intro. If you would like for me to do longer videos where we just go ham with studying for hours and hours, let me know. I'll try to accommodate that. Really and truly, I don't study for hours and hours, but for the sake of just, I guess, companionship or learning, we can do some videos together like that. But let me know if you'd like me to link these PDFs. Happily to share them with you. Again, this is something that you guys can do on your own. But this is like an intro just to kind of give you a framework as to how it is that I approach questions, how it is that I approach studying, and I hope it helped. Let me know. I'm interested to hear your feedback, everybody. I'm new to this and just really trying to help everybody is the best way I can. So don't forget, like, subscribe, comment, engage, interact, share, bookmark, all the above. Let's build this community together. We're all trying to help each other. And this is how we're going to bridge the gap. Thank you, guys.